I need you to stop for a moment. Not because I want to scare you, because I want to protect you. Right now, somewhere in this country, an older adult is sitting across from a surgeon. The doctor is confident, the paperwork is ready, and everything in that room is moving forward like the decision has already been made, but nobody in that room is saying what I'm about to say to you. For a body over 60, surgery is never just surgery. It's a full assault on every organ you have: your heart, your kidneys, your liver, your brain, all of them, hit at once. And 3 surgeries in particular, 3 procedures that get recommended constantly to people your age, carry risks so serious that most patients never fully understand what they're agreeing to. Not because surgeons are careless, but because the appointments are short, the paperwork is long, and the real conversation almost never happens. Stay with me, because what I'm about to share could be the most important thing you hear before you ever sit across from a surgeon again. Here's what most people believe. They believe that if a doctor recommends surgery, someone already weighed the risks. Someone already considered your age, your history, your body. I understand why you'd think that. I did too, early in my career. But after more than 20 years in preventive medicine, working with thousands of patients over 60, I've seen something that changed the way I practice. The surgery can go perfectly. No mistakes, no errors in the operating room. The surgeon does exactly what they planned, and the patient still never comes back to who they were. Not because of the disease, because of the operation itself. That is not a rare story. That is a pattern. And it happens more often than anyone admits. Here's what we're going to cover today. I'm going to walk you through 3 surgeries that are routinely recommended to adults over 60, but carry hidden dangers that almost never come up in the pre-op conversation. I'm going to show you why the older body responds differently, in plain, honest language you can actually use. I'm going to give you 4 specific questions you should ask before agreeing to any major procedure, and I'm going to tell you about 2 patients, Raymond and Dorothy, whose stories I still think about. Because what happened to them is exactly what I want to help you avoid. Now, the 3rd surgery on this list is the one that surprises people most. It seems so routine, so standard, so we do this all the time. But in patients over 70, it carries a risk that I believe is one of the most underreported facts in medicine today. You'll want to stay for that one. Let's get into it. Before I talk about the surgeries, I need you to understand one thing, because once you understand this, everything else will click into place. When you're in your 30s or 40s and you go under general anesthesia, your body has what I call reserve. Your heart surges when it needs to. Your kidneys flush out anesthetic drugs within hours. Your brain clears the fog by the next morning. But here's what happens as we age. That reserve quietly shrinks, not dramatically, not all at once, but year by year, it pulls back. By the time someone is 72 or 75, the heart's ability to handle sudden pressure has dropped. The kidneys process medications far more slowly. The liver metabolizes drugs at a fraction of its former speed. And the brain, this is the one I want you to remember. The brain becomes destabilized by general anesthesia in ways that can last not hours, not days, but weeks, sometimes months. There's a medical name for this: post-operative cognitive dysfunction, POCD. In patients over 70, it occurs in an estimated 40 to 60% of major surgeries. I say that number in consultations, and the room goes quiet every time, because nobody mentioned it in the pre-op appointment. Now add something called frailty. Frailty is not about looking old. It's a measurable medical state, where the body's physical reserves have dropped below a critical threshold. And here's what most people don't know. You can have frailty and still look completely fine. You can be driving, cooking dinner, going to church, and still have a frailty score that places you in a high-risk surgical category. Roughly 1 in 3 adults over 70 meets the clinical criteria for frailty. That is the body we are talking about when we discuss these 3 surgeries. Hold that picture in your mind. My name is Dr. Ben Bates. I've spent over 2 decades in preventive medicine, focused specifically on aging and longevity in adults over 60. I've worked alongside surgeons, oncologists, cardiologists, and orthopedic teams. I've reviewed surgical outcomes, I've sat in ICUs, and I've had the hardest conversations. The ones that happen after the procedure, when families are standing in hallways asking questions nobody prepared them for. I'm not here to frighten you. I'm here because you deserve the full picture, not a brochure, not 10 rushed minutes before you sign something. The full picture. Let's get into the first surgery. I want you to raise your hand, figuratively, if someone you know has had back surgery. I already know most of you just raised your hand. Back pain is the #1 complaint I hear from patients over 60, and spinal fusion, where 2 or more vertebrae are permanently locked together with metal rods and screws, is being recommended at rates that genuinely worry me. Let me tell you about Raymond, 68 years old, retired contractor, active man, loved fishing on weekends. He came to me after a spine surgeon told him he needed a 3-level lumbar fusion. Metal rods, screws, permanent hardware in his lower back. He sat across from me and said, "Doc, I just want to walk to the end of my dock again." Simple wish, completely reasonable. But when I reviewed his full health profile, his bone density, his heart function, his current medications, I saw something that made me slow down. Because here's what the research actually shows. A major study on patients over 65 with degenerative disc disease, the most common reason this surgery gets recommended, found complication rates exceeding 40% after complex spinal fusion. 40%. And these were not minor complications. Blood clots, deep infections, hardware failure, screws that loosen and shift inside the spine months later. And then there's something called adjacent segment disease. Most patients have never heard of it. Here's what it means. When you fuse a section of the spine, that section becomes permanently rigid. The vertebrae above and below it now absorb all the movement that used to be spread across multiple joints. Over time, sometimes within 2 or 3 years, those neighboring segments start breaking down faster than they naturally would. You fixed one section, and now the sections beside it are deteriorating at an accelerated rate. So you go back for another surgery, and the cycle begins again. Here's what frustrated me most when I studied this closely. For patients with chronic degenerative back pain, not a fracture, not a tumor, not active cord compression, but the kind of chronic aching pain millions of older adults live with. The long-term pain relief from spinal fusion is statistically no better than a properly designed physical therapy program combined with targeted injections. Same outcomes, dramatically higher risk. Now, I want to be precise. If you have active spinal cord compression, if you're losing bladder control, if weakness is developing in your legs, surgery belongs in that conversation immediately. But elective fusion for chronic pain alone? That requires a much longer conversation than most patients are ever given. Raymond and I talked through his options. He entered a structured spinal rehabilitation program with a specialist who built a plan specifically for him. 3 months later, he called me. "I walked to the end of my dock last Saturday," he said. "Then I turned around and walked back. Twice." He never had the surgery. But here's where it gets even more complicated. Because the second surgery on this list involves a word that shuts down rational thinking almost instantly. When someone hears the word cancer, something changes. Every instinct screams, remove it, cut it out, do whatever it takes. I understand that completely. After 20 years in medicine, I still feel the pull of it. But here is what those same 20 years have taught me. The goal of cancer treatment is not simply to remove the tumor. The goal is to give the patient more good years of life. And sometimes, not always, but more often than anyone says out loud, aggressive surgical resection in a frail older adult moves that person away from that goal. Let me tell you about Dorothy, 78 years old, retired school teacher, sharp as anyone I've met. She grew tomatoes, peppers, and herbs in her backyard every summer. She came to me after being diagnosed with a slow-growing colon tumor, localized, not spread. Her oncologist recommended a major bowel resection. Hours under general anesthesia, weeks of recovery. Dorothy also had moderate heart failure, type 2 diabetes with kidney involvement, and mild but documented cognitive changes. She looked at me and asked, "Dr. Bates, should I do it?" And I gave her the honest answer. That depends on what we're actually weighing. Because here's what the data shows in cases like hers. A landmark review from the American College of Surgeons examined elderly cancer patients who underwent major resections. Nearly 1 in 5 experienced what's called failure to rescue. Let me tell you what that phrase means in plain terms. A complication occurs during recovery, and the body, already stretched by heart disease, by diabetes, by frailty, cannot pull itself back. The surgery removed the tumor, and the patient still passed away within weeks, not from the cancer, from the operation. Now, I want to be completely clear. For a healthy 67-year-old with strong organ function, surgical resection of a localized cancer can absolutely be life-saving. No question. But for a 78-year-old with Dorothy's profile, the math is different. Targeted radiation, immunotherapy, active surveillance with close monitoring. These are not surrender. These are legitimate, evidence-based paths forward that carry a fraction of the physical cost, and for certain patient profiles, comparable or better outcomes. Dorothy and I talked for a long time. She chose localized radiation combined with close monitoring, working directly with her oncologist. 2 years later, she was still in her garden, still sharp, still herself. She told me, "I didn't lose a single season out there." That sentence stays with me. Here's the question I want you to sit with, or ask on behalf of someone you love. If the goal is more good years of life, what is the best path to that goal for this specific body? Not the average patient, not the person in the clinical trial, this body, right now. That question changes everything. And now, surgery number 3. This is the one that surprises people most, because it doesn't feel like a choice. I want to pause and ask you something directly. Have you, or has someone you love, ever been told before a surgery, "This is standard, you'll be fine"? We do this all the time. Type yes or no in the comments right now, because that phrase is technically true, but it tells you nothing about your risk. It tells you about the average patient. And you are not the average patient, you are you. Here's what surprises people about surgery number 3. It's not the surgery itself, it's the fact that it's not always a choice. Emergency abdominal surgery for a ruptured bowel, a severe blockage, internal bleeding, doesn't come with an appointment. It finds you. So why is it on this list? Because knowing what this surgery does to a body over 75 before that moment arrives changes how you and your family respond when there's no time to think. And that difference between walking into that moment with knowledge versus walking in blind can change everything about what comes next. Here are the numbers. Emergency abdominal surgery in patients over 75 carries a mortality rate between 30 and 50% in severe cases. 30 to 50%. Not because surgeons aren't skilled, not because hospitals aren't equipped, because an older body hit by sudden abdominal trauma is fighting on every front at once. The liver is stressed, the kidneys are overwhelmed, the heart is working harder than it has in years, the lungs are fighting fluid buildup, and what happens next in an older body, a cascade called systemic inflammatory response syndrome, where unchecked inflammation begins pulling organs down, one after another, is as serious as it sounds. And it is far more common than most families know until they're already standing in that corridor. So here's what you can actually do with this information. First, do not ignore abdominal symptoms, persistent bloating that won't resolve, aching pain in the lower abdomen that comes and goes, unexplained changes in bowel habits, nausea with no clear cause. These are not automatic emergencies, but in someone over 60, they deserve a prompt conversation with your doctor. A problem found early, a blockage on a scan before it ruptures, a growth identified before it perforates, can almost always be managed with far less risk than emergency intervention. Early attention is one of the most powerful tools you have. Most people don't use it. Second, have the conversation with your family now, not in the ER. Now, this week. What are your wishes if emergency surgery becomes the only option? What does quality of life mean to you? What are you willing to go through? And what are you not? This is not a morbid conversation. It is one of the most loving things you can do for the people who will be standing in that corridor, trying to make a decision in minutes that you could have helped them with months earlier. I've watched families torn apart, not by grief, but by uncertainty, by not knowing what their person would have wanted. Don't let that be your family. Now let me give you something you can take into any surgical conversation. 4 questions. Write them down. Question 1. What happens if I don't have this surgery right now? A good surgeon will answer that directly. If nothing urgent changes over the next several months, you have time. Time to think. Time to get a second opinion. Time to prepare your body properly. If the answer is vague or evasive, that is information too. Question 2. Is there a less invasive alternative for someone my age? Medicine has changed dramatically in the last 15 years. Procedures that required open surgery a decade ago can now be done through a catheter, through a small incision, or through targeted therapy that never touches general anesthesia. Surgeons naturally lead with what they know best. Make them show you every option on the table. Question 3. What does recovery realistically look like for my specific health profile? Not the average patient. You, your heart, your kidneys, your medications, your home situation. If the answer sounds like a brochure, push back. You deserve a specific answer. Question 4. What is your personal complication rate for this procedure in patients over 70? Surgeons track this. Hospitals track this. The numbers exist. A confident surgeon answers that question without hesitation. And if that question creates discomfort, a pause, a deflection, an irritated look, that itself tells you something. I want to tell you about one more patient before we close. His name was Martin, 72 years old, former high school football coach, big man, strong handshake, not someone who asked for help easily. 2 different surgeons had recommended a knee replacement and a spinal fusion, both possibly within the same year. He sat across from me and said, "Doc, I'm not afraid of the knife. I'm afraid of going in as myself and coming out as someone who needs to be taken care of." I've heard that fear more times than I can count. Different words, different people, but the same thing underneath, the fear of losing yourself. We spent a long time going through his full picture, not just his blood work and imaging, his goals. He wanted to coach his grandson's little league team. He wanted to walk his daughter down the aisle at her wedding in 8 months. He wanted to wake up in the morning without dreading the day. We built a plan together. Targeted rehabilitation, joint injections, anti-inflammatory nutritional strategies, no surgery, at least not yet. 8 months later, Martin walked his daughter down the aisle. He called me the following week and said, "I was there for every single step." That is what this is about. Not avoiding surgery forever, not refusing medical care, making the decision with your eyes completely open, being present for what matters, being yourself. Let me bring it all together. 3 surgeries that carry serious underreported risks for adults over 60. Elective spinal fusion, where complication rates exceed 40% in older adults, where adjacent segment disease can start a cycle of repeated procedures, and where non-surgical alternatives offer comparable pain relief with a fraction of the risk. Major cancer resection in frail patients, where the goal must always be more good years of life, and where for certain patient profiles, non-surgical treatment produces equal or better outcomes than aggressive surgical removal. Emergency abdominal surgery, where the mortality risk in patients over 75 is staggering, and where your most powerful tools right now are catching symptoms early and having an honest conversation with your family before the emergency ever happens. And the 4 questions to take into any surgical appointment. What happens if I don't have this surgery right now? Is there a less invasive alternative for my age and health? What does recovery actually look like for my specific profile? What is your personal complication rate for this procedure in patients over 70? Write them down. Bring them with you. Use them. Here is what I need you to carry with you after today. A surgical recommendation is not a verdict. It is the beginning of a conversation, and that conversation belongs to you. You have every right to slow down, to ask hard questions, to request alternatives, to get a second opinion or a third, without guilt, without apology, without explanation. Your age is not a weakness in that room. Your self-knowledge, your clarity about what matters, your understanding of your own body, those are your greatest assets. The surgeon holds the scalpel, but you hold the choice. And a choice made with complete information, with clear eyes and full understanding, is the most powerful medical intervention available. More powerful than anything I have ever seen performed in an operating room. If something in this video gave you pause, if you thought of a surgery you or someone you love is considering, type the word question in the comments. I read everyone. If this gave you something to bring to your next appointment, something to share with someone you love, please share it. One share this week might be the most important thing you do for someone's health. Subscribe if you haven't already, because what I share here are the conversations that should happen in every doctor's office. They just usually don't. Take care of yourselves. Stay informed. Keep asking questions. Your body has more resilience than you've been told, but it needs you to ask the right questions first. Everything in this video is general medical information based on published research and clinical experience. Every individual situation is unique. Before making any decision about surgery or treatment, please have a full, honest conversation with your own physician or specialist. That conversation, unhurried, direct, and informed, is where good medicine begins.